everyone. I hope you are hearing me well. I'm Dr. Ulukaya Durakbaşa. I'm gonna co-chair this session with Dr. Evritaş Gürkan. And firstly, I'm glad we have managed to organize this online PAAFIS meeting this year. And I especially thank Dr. Tutku Soyer for his tremendous effort for gathering us this year in this meeting. I also thank all participants. In this enteral feeding session, we have three distinguished speakers, and we will have the answers to the questions at the end of each speech. Our first speaker is Assistant Professor Hayriye Hızarcıoğlu Gülşen from Department of Pediatric Gastroenterology, Hacettepe University. And Dr. Gülşen, please.
You. Thank you, dear chairpersons, and hi everyone. Good morning or good afternoon where you are. I also would like to thank to Dr. Soyer and organization committee for giving me this opportunity to talk in this webinar. I'm going to talk about enteral nutrition strategies today. I have no conflict of interest. My objectives are mentioning historical development of enteral nutrition as well as defining in the indications of enteral nutrition. We're going to talk about the creative decision tree in formula selecting and when to start a child after a surgery, when to start to feed a child, and what is on the next in enteral nutrition world. As you know, before COVID, our new BC, we used to have meetings in big conference hall. Now our meetings a little bit resembling Muppet Show. We are just talking and cannot see all of you. And also our eating habits have been destroyed. People are really doing mind-boggling things to eat while wearing a mask. But the only thing that has not been changed during this period is the importance and the uniqueness of human milk. And when we look at the timeline of enteral nutrition, we see that enteral nutrition implementations was started by rectal feeding. It's very interesting. In 1550 BC, ancient Egyptians gave rectally of some food to heal the rectal mucosa, to reduce the rectal inflammation as well as to support nutrition. During 3,500 years, this implementation goes on, and several trials were done until 1950s during this time. And the most famous case of rectal feeding is the President Garfield of United States. He had a gunshot and fed by rectally with peptonized beef as well as whiskey during 7 to 9 days. It's very interesting. Upper GI tract feeding was first described in 12th century, and it was first started at the end of 16th century by Capivaccius from Venice. He put a hollow tube into the esophagus to push a liquid down to it. And after then, some esophageal feeding trials also came into place. By 1710, we see the intragastric feeding implementations. During 100 years, orogastric or nasogastric feeding were tried. Sorry. Traumatic gastroenterous fistulas are the forerunners of gastrostomies as a planned surgery. It was first started on dogs, first tried on dogs in 1837, and 12 years later on humans. We see in the timeline there are lots of survived patients with gastrostomies, and the green ones are also pediatric patients. By 1894, Martin Stem, whose name was given to the procedure, standardized the technique of gastrostomy. Jejunal feeding was started during these years, and the first successful jejunostomy was performed in 1878. What happened then? A few kinds of different operations of gastrostomies was introduced, and by 1980, percutaneous endoscopic gastrostomy was introduced. By 20th century, nasoduodenal or nasojejunal tube feeding, as well as drop-by-drop duodenal feeding, who are the forerunners of continuous feeding, were introduced. And nearly 9 years later, after PEG, we see here percutaneous endoscopic jejunostomy. When we look at the timeline of enteral formulas era, we see that the timeline starts with 1918, when the basal metabolic rate was calculated. Firstly, milk-based infant formula was released. Then allergic formulas were introduced in 30s. In 1950s, we see first commercial powdered mixtures. And in 1960s, it's very interesting. NASA requested to eliminate the disposal of human waste of astronauts in outer space, and they requested a diet. And the researchers described an elemental diet for the astronauts, but because of the low palatability, NASA rejected it. So elemental diet came into our lives as a solution for severe GI complications like malabsorptions. After then, nearly 50 years ago, adult formulations came into our lives, and 15 years later, fiber-fortified formulas released. And finally, in 1995, FDA approved enteral nutrition as a drug. Has anything changed about the nutrition definition? Yes, traditionally it has been regarded as delivery of food beyond the esophagus via tube, but now by 2006, it's been said that not only via tube feeding, as well as provision of specialized oral nutritional supplements are included under the definition of enteral nutrition. There are two main indications for nutritional support. The first one is insufficient oral intake, and the second one is wasting and standing. I will talk about the insufficient oral intake. If a child does not have ability to meet his 60 to 80% of individual requirements for longer than 10 days, or if a child older than 1 year old who's not going to be fed within 5 days, or a child who's not going to be fed within 3 days who is under 1 year old, can be accepted as a nutritional support candidate. There are also some clinical situations for enteral nutrition. Inadequate oral intake is the most important one. Disorders of sucking and swallowing, a good example is cerebral palsy, as you know, or congenital abnormalities of upper airway or upper GI tract, like esophagus atresia. Tumors, trauma, critical illnesses, severe gastroesophageal reflux, and food aversion are also under this topic. Any digestion or absorption disorders, such as short bowel syndrome, inflammatory bowel disease, or cystic fibrosis, needs enteral nutrition support. And chronic solid organ disease like chronic renal disease, congenital heart disease, or cystic fibrosis also required increased energy. Disorders of gastrointestinal motility, as well as non-organic growth filtering, also may need enteral support. Also, there is a new group which is very important, primary disease treatment. For example, in Crohn's disease, for the last 10 years, we are using exclusive enteral nutrition for remission induction instead of steroids, which is very spectacular. And when we talk about enteral formulas, we know that formulas are mostly liquid, and some of them may be powdered. Enteral formulas are balanced, mix of all essential nutrients needed for the physiological requirements as well as growth. And they are designed to serve as a sole source of nutrition. So how can we pick a formula? You have to create a decision tree in your mind. You need some criteria, major and minor. Now let's talk about them. The most important major criteria is age, because we have to think about the age of the patient. You may give infant formula to the patients under 18 months old, or patients under 2 years old and who has a weight under 8 to 9 kilograms. Pediatric formulas can be given to the patients who are older than 1 year old. What about adult formulations? Can we use them? If you don't have pediatric formula in your hospital and the child is older than 10 years old, you may use, because we know that adult formulations include higher energy from protein and high vitamin and mineral contents when compared to pediatric solutions. The second major criteria is energy density. We have isocaloric formulations. Most of them are 1 kilocalorie per milliliter. They meet full nutrient and fluid requirements. We also have hypercaloric solutions, and most of them in Turkey is 1.5 kilocalorie per milliliter. They are used for increased energy requirements. They meet nutrient requirements, but we have to be careful about that. They may provide insufficient fluid, so you have to give more fluid to these patients who are using hypercaloric formulations. Protein content is also important. Most of the standard formula around are polymeric, but we do also have low molecular weight hydrolyzed formulas. There are 2 kinds of hydrolyzed formulas. One is oligomeric, which means peptide-based. The other one is amino acid-based, which means elemental formula. Oligomeric formulas can be divided into 2 according to their molecular weight as partially hydrolyzed or extensively hydrolyzed. Polymeric formulas contain whole protein from cow's milk, and some of them can be whey-based, some of them can be casein-based. Whey-based formulas contain biologically high whey protein, as you know, and it's important because whey helps stomach to empty easily. Most of the polymeric formulas are gluten-free, as well as low molecular weight formulas. This is an advantage for celiac disease patients because celiac disease patients can safely use it. Hydrolyzed formulas also have some advantages like complete absorption, hypoallergenicity, no lactose or no gluten content, and MCT containing. I'm going to talk about what is MCT later. They do have disadvantages also, low palatability, which is very important, high osmolarity. You cannot give them bolus into the jejunum as they cause osmotic diarrhea. You should give them continuously with a pump. And they are also expensive. The smaller the molecule, the more expensive it is. Don't forget it. Where do we give extensively hydrolyzed or amino acid-based formula? Extensively hydrolyzed formula can be used in malabsorptive disorders like short bowel syndrome or cholestatic liver disease such as biliary atresia, or in jejunal feeding. In food allergy, which cause serious problems like anaphylaxis, which means IgE-related allergy, or in case of intolerance to extensively hydrolyzed formula, you may use amino acid-based formula. And also severe malabsorption that doesn't respond to extensively hydrolyzed formula, amino acid-based formula can be used. As I said before, flavor is very important. There is a new study from Italy. They're comparing milk and other hydrolyzed formulations, taste, smell, and some features. They found that smell, taste is better in whey-based extensively hydrolyzed formula, and persistence of unpleasant taste is shorter in this formula. There's also a study from Turkey about malnutrition. They compare, they try to find out the adherence criteria of treatment, and they show that with standard formulas, nutritional product related factors associated with the treatment adherence were cost and flavor. Flavor is really very, very important. The 4th major criteria is sites of delivery. You may give orally, via tube, or combined. If you have a functional gastrointestinal tract, please use it. If you can do it, please oral feed the child. If you have to use a tube, think about the integrity of the GI tract, duration of enteral nutrition, risk of aspiration, feeding tolerance, and compliance of the patient as well as the family. In gastric feeding, you may use orogastric or nasogastric way or permanently gastrostomies. In transpyloric way, you may use nasoduodenal, nasojejunal, or gastrojejunal tubes as well as jejunostomy. We just use orgastric feeding in patients with, who have prematurity, as they cannot swallow easily, functionally, or in case of nasopharyngeal obstruction. How can we choose which way we're going to use? Let's look at practical approach. If you have a functional gastrointestinal tract, please use it, because it's more physiological, cost effective, and have low infection risk. The second topic is thinking about the duration. If you're going to feed your child, the patient, shorter than 4 weeks, you may use temporary solutions. If you're going to feed the child longer than 4 weeks, you have to think about permanent solutions like gastrostomy or jejunostomy. The third point is you should think about aspiration risk. If there is aspiration risk, transpyloric feeding should be preferred. Feeding intolerance, gastroparesis, gastric outlet obstruction, or significant reflux may also be the other reasons for transpyloric feeding. There's a recent study from a surgery paper, from a surgery journal. They're comparing percutaneous gastrostomy and laparoscopic gastrostomy. They found that laparoscopic gastrostomy is safe enough, even they say it's more safe. And they suggest that it can be preferred in newborns, children with significant skeletal malformations, and who has had previous abdominal surgery. So it's a very important paper. In gastric feeding, we have advantage of being physiological. We can position the tube easily. We can use large tube, and stomach is a reservoir, can include large volume of feeding. In post-pyloric feeding, we don't have these advantages. It's not physiologic. You should give it continuously, and you should increase the volume gradually, because you may cause dumping syndrome. And a thin tube is needed, so plugging and dislodgement may be a problem during post-pyloric feeding. Gastric emptying is also a problem in gastric feeding. It can be delayed by high energy, volume, osmolarity, high fat content, and protein type also affected. A paper from European Journal of Clinical Nutrition revealed that whey protein is very important on gastric emptying, because they compare different energy densities, containing different energy density formulas, which of them are whey-based, and they did not find any difference. So they say that whey-based formulations can be easily used, can be safely used, even they have high energy density in gastric emptying. What about the tube feeding side and respiratory outcomes? We see that aspiration and pneumonia decreases when the tube is put beyond the duodenum. We are using transpyloric feeding for the risk of gastroesophageal reflux. Do we have gastroesophageal reflux during transpyloric feeds? Yes, says this article. There is more reflux during transpyloric feeding periods than non-feeding periods. So it's also important in transpyloric feed. There are different kinds of delivery modes. You may feed the child with bolus feeding with a syringe or with a gravity set. It may take 10 to 15 or 20 minutes at most. Intermittent feeding may take 1 to 2 hours for a meal. Continuous feeding means feeding a child with a pump during whole day, or you may use combined feeding, for example, feeding with a pump during night and let him move around in the morning and bolus feed. Bolus feeding has advantages of being physiological. Continuous feeding have advantages of high tolerance, easily absorption, and low thermogenic effect, which means low energy consumption. So you may use it in malabsorption, feeding intolerance, and post-pyloric feeding. There are also some minor criteria for enteral formulation selection. First one is osmolarity. High osmolarity formulas, they are low molecular weight formulas, can cause diarrhea, nausea, vomiting when you give it bolus into the duodenum and beyond. Fat content is also important. MCT, medium chain triglycerides, enriched formulations contain higher MCT, than standard formula, but they still have LCT. They do less need bile acids or pancreatic enzymes for absorption. Also, they do not need micelle formation for absorption of lipids. So they bypass this system. They can be passively diffused into the portal system. In which disorders we may use MCT enriched formulations according to this pathophysiology, fat malabsorption. For example, severe cholestasis in biliary atresia, exocrine pancreatic deficiency, short bowel syndrome, and lymphatic system disorders like lymphangiectasia, primary or secondary to a reason. Fiber is maybe the most important minor criteria of enteral formula selection. Soluble fiber fermentation products are short chain fatty acids. They do have positive effect on intestinal physiology. They prevent diarrhea. Insoluble fiber prevents constipation by entrapping water and bulking effect. So new approach is combination of both soluble and insoluble fiber to prevent constipation and diarrhea. There is also one study from Turkey, a multi-center study, which revealed a high fiber enteral formulations are safe and good functioning in improving anthropometrics of malnourished children. Immune nutrition also important. By 1990s, we see that some immune-enhancing nutrients are added into formulas to lower infection rates and shorten the length of the hospital stay. I have to mention two specific disorders for pediatric surgeons and nutrition approach. The first one is esophageal atresia. As you know, we encounter lots of GI problems in following up esophageal atresia. One of them are feeding difficulties due to dysphagia and dysmotility. ESPGHAN and NASPGHAN, our societies recommend intensive early enteral and oral nutrition besides neonatal care and surgery to reduce the risk of post-operative malnutrition. Nutrition is really important in these patients. Are there any negative or positive predictive factors for oral feeding in these infants? Yes, there is a study from Canada. They revealed that cardiac anomaly or corrected gestational age has a significant negative predictive effect on exclusive oral feeding at discharge home. And is there any positive predictor? Yes, transanastomotic feeding, early transanastomotic feeding is a positive predictor effect for the parental nutrition discontinuation. We encounter several feeding difficulties during their whole life, like eating slowly, refusing meal, coughing, choking during meals, and vomiting. What can we do for it? I can only mention what can we do if the patient has oropharyngeal dysphagia, and we may thicken the formula because it improves swallowing, reducing aspiration, but don't forget, it reduces regurgitation, but it does not have effect on reflux index. And these patients should be followed by a multidisciplinary approach.
Dr. Gülşen, I think can you conclude? Can you conclude your speech, please? The time is up.
Okay. In intestinal failure, we also use breast milk for infants and polymeric formula for older patients. Try to switch to polymeric formula to stimulate the intestinal absorption. Is there any study for early nutrition feeding? Yes, for the child, there's a new literature, but they cannot show, this systemic review cannot show any advantage of NPO, no clear disadvantage of early feeding, no evidence of early feeding complication. So larger studies are on the trial. What's on the horizon? After the Human Genome Project, nutrigenomics occurred, and we know that it is the study of the effects of how specific genes and bioactive food component interact, if food have any effect on gene expression, how genetic variations affect the nutritional environment, and personalized approach to preempt chronic and metabolic disease are aimed on the horizon. My take-home message: standard polymeric formulas are safe, and they do have the fibers can be considered as useful. You may use protein content or MCT-based formula in specific conditions, and for surgeons, underfeeding during the post-operative course causes post-operative complications. Please don't forget it. Thank you.
Thank you. So, you may write if you have any questions for the speaker. I am currently checking the questions, and there's one question from Dr. Iman Amrun, and the doctor is asking about the complementary feedings in esophageal atresia patients. How do you begin? When do you begin? And what sorts of feeding strategies do you have specific for esophageal atresia patients? I suppose this is a question about oral feeding, of course.
Yes, I got it. In oral feeding, if you don't have any swallowing problems, if the patient can consume thickened formula, they may start complementary feeding as the other children. At 6 months, if they are ready to feed with the complementary.
Dr. Gülşen, you're muted now. Can you open the volume, please?
Is it okay now?
Yes.
Okay, sorry. Do you want me to start again?
Yes, please.
Okay. For esophageal atresia, there is no different time of complementary feeding if the patient can swallow thickened food. For esophageal atresia, if there is a swallowing problem due to the anastomotic strictures, it's another work. You have to wait for it. But if there is no problem with the swallowing, you may start it as the other children at 6 months old is okay.
Okay, thank you. Then we have concluded this speech. Now Dr. Eğritaş will go on with the next speech.
Hello, everyone. I hope all of you are doing fine. We have a great topics for pediatric gastroenterologists, pediatric surgeons, and also general pediatrician, I think. Before announcing our speakers, I would like to kindly remind you, if you have questions for our speakers about their topics, please send a message. And every end of each topic, I'm going to read your questions, and our speakers would be glad to answer all of the questions. Okay. Of course, as well as time allows us. Our second speaker is from New York, very far away, Dr. Thomas Serra. Good morning, Dr. Thomas. How are you? I can't hear you. Sorry.
Can you hear guys now?
A little bit.
Okay. Well, good morning from New York.
Yes, I think it's very early time in the New York, right?
Yes, it is.
All appreciate you from Turkey. Okay, Dr. Thomas, he's going to talk about tube feeding in neurologically impaired children. What is the best tube, best formula, or best outcome? Please welcome Dr. Thomas. Our ears on you.
Okay. Let's see. Can you guys see my screen?
Yes.
Perfect. All right. So today I will talk about tube feedings in a specific group of children, in children with neurologically impaired problems. So first of all, I would like to thank Nutricia for allowing us to have this webinar. I think this is very useful and it's going to teach us all, a lot of information. Two is I would like to also thank PAAFIS board for coming up and being so proactive and creating those webinars and meetings in person over the past few years, especially Professor Tutku Soyer for, going out of the league and organizing the first PAAFIS webinar. Well, let's go to the presentation. I have nothing to disclose, unfortunately, but today we'll talk about a few things. So first, we're going to try to define the neurological impairment, and then we're going to talk about the tubes, formulas, and outcomes, and see if we can identify which one is the best out of the group. So I think one of the better definitions of it is that neurological impairment means that there's a capacity of your nervous system that has been affected and limited or impaired, and that leads to difficulties in which are exhibited in one of them more of the following areas: the use of the memory, the control and the use of cognitive functioning, sensory and motor skills, speech, language, organizational skills, information processing, affect, social skills, or basic life functions. And I think this very well encompasses a lot of kids that we tend to see both in the GI and the surgical clinics. Now, most of the kids that we all encounter, and then basically this webinar is a lot about the pediatric patients, are the children who have genetic causes to their neurological impairments. So genetic abnormalities and specific trisomies frequently going to present with neurological impairment. Metabolic disorders, as well as the insults on CNS itself. So structural abnormalities, hydrocephalus, very severe seizure disorders, trauma, infection, and vascular accidents. Now, the tubes, as had been mentioned, have been used for a long period of time. The earliest recorded description comes from the papyrus from 3,500 years ago, which is a long, long time ago. And I stated before, even the ancient Egyptians and Greek were using the tube feedings, mostly in the form of the enemas, to provide nutrition to our body to heal and to prevent sickness. The solutions that they have used were solutions that were available to them at that time. So wine, milk, hay, wheat, or barley broths. And later on, as we progressed through the millennia, eggs and barley started to be added. Now, the rectal feedings have been a method of choice for hundreds of years. And the main reason for it is that it's so much easier to provide a solution into the rectum as opposed to solution into your upper GI tract, which wasn't available until later on in medieval times. The first gastrostomy tube that was described was 1894, and then what we did, we progressed and we started to apply and do percutaneous endoscopy gastrostomy, which wasn't until almost 100 years later. And one of the first description of the laparoscopy-assisted gastrostomy wasn't until the 1997 by Anderson. Now, what are the indications for the tubes? We're clearly going to concentrate on neurologically impaired children. However, there's a number of other patients that will require tube feeding. So patients with abnormal and structural abnormalities, patients who have feeding difficulties, especially oral motor dysfunction that can lead to aspiration, a lot of children that we see that tend to have failure to thrive, patients who had the surgery and have a short bowel syndrome, in some patients who have post-surgery, and some patients who have a very significant GI dysfunction. Now, there are a number of tubes, and depending on where you come from, which part of the world, which institution, pretty much if you look to the right side, those are the tubes available to us. So either nasogastric tubes or nasoduodenal or nasojejunal tubes, all of them gonna clearly, the name gonna follow the insertion point and the end point of the tube. There's some institutions or some instances when you cannot use the nasal passages for the tube placement, so people will do orogastric or duodenal or jejunal tubes. We're very familiar with gastric tubes and gastrojejunal tubes and jejunal tubes themselves. And clearly out of all those groups, the nasogastric, nasojejunal, gastric, and sometimes jejunal tubes will be the most frequent ones that we encounter in our daily practice. And the considerations that we have when we decide on a tube placement is, what is the duration? I mean, is this the tube that's going to stay for a few days, few weeks, few months, or the rest of the life of the child? What is the anatomy that we're dealing with? Is it going to be placed endoscopically, or you need the surgeon to actually help you place the tube? What is the aspiration risk? What are the parental and medical preferences? A lot of times we might not agree on the same tube because there come aesthetics and complexity of the tube that parents want to go with one tube choice, and the medical professional might think that the other tube choice will be a little bit better. What is the family reliance? Are those people reliable to take care of that tube? You know, nasogastric tube is very different than jejunal tube. What is the cost? Cost becoming a very important lately and drives a lot of medical decisions. What are the infusion devices that we can use with those tubes? And the list goes on and on. So there's many conflicting, factors that you have to think about when you talk about tube placement. So if you collectively look at the nasogastric tubes, I mean, they're widely available, they're usually quite cheap, and they're very easy to place and replace. And that makes a difference because a lot of patients and families can be taught how to place those tubes at home. Now, the problem is aesthetics. So clearly, if you have an infant who is, let's say, 2 weeks old and you have an NG tube, it's not a big deal. But if you have a young teenager girl, having a tube sticking out of the nose, it's not going to be something that she will readily accept. Those tubes tend to be easily dislodged, intentionally or unintentionally. They can affect oral skills development. They can cause nasal septum perforations if they stay too long, and they're prone to clogging because they are usually pretty long. Gastric tubes, seem to be a happy sort of medium. They're widely available. They're very easy to maintain once they're placed and appropriately and healed. You can use them for a variety of functions, so feedings, medications, and venting. They tend to stay in place and they tend to be very secure unless you have, let's say, a balloon pop. But even with that, a lot of times they can be replaced at home. They allow for the oral skill development, and because they're much shorter, they cause less clogging. Anesthesia, however, is something that is necessary for most of the time to place those tubes. The cost is a little bit more expensive because of all the surgery or endoscopic procedures to do so. They can have buried bumper syndromes, and they sometimes are prone to leakage. Jejunal tubes clearly are used for a very specific group of patients. They're bypassing the stomach, so you're providing nutrition directly into the small intestines. They will allow you for oral feeds to develop, and once they're placed, and they typically placed by surgeons, they're difficult to dislodge. I mean, they can flip and they can be different issues, but they usually stay in place quite well. Now, the problem is they're not readily available. You require anesthesia for the placement. The cost is usually more expensive. They can leak and they can clog, and replacement can be difficult because you usually require either intervention, radiology, or surgeons to do so. Now, there are some contraindications for tube placement, so absolute and relative contraindications. The absolute contraindication is going to include uncorrectable coagulopathy, gastrointestinal tract obstructions, clear interposition of enlarged organs, if you have a frank peritonitis or you have a patient who has high hemodynamic instability, if you have severe ascites, or if you have abdominal wall infection at the site where you want to place the tube. Some of the relative contraindications include active gastritis or peptic ulcer disease, coagulation or bleeding disorders, previous abdominal surgery, ascites depending on the severity, if you have moderate to severe kyphoscoliosis, especially if the one that's going to progress, peritoneal dialysis, and ventriculoperitoneal shunts. Some of the complications, remember, we're putting a foreign object in the human body. There can be complications. So major complications will include fistulas, internal leakage or peritonitis, bleeding, gastric outlet obstruction. Some patients can develop necrotizing fasciitis with subsequent subcutaneous abscess formation. They can develop Barrett's bumper syndrome. They can have internal organ injury, which typically tends to be colon in PEG tubes. Some minor complications, tube blockage, transient gastroparesis, which is usually in the setting of anesthesia, gastric wall ulceration, overgranulation tissue, which usually we are able to deal with quite well, stomach-site infection, and pneumoperitoneum. But if you look at that aspect, up to 50% of PEG tubes will have some pneumoperitoneum on the follow-up X-ray. Those tend to resolve quite well. So the bottom line, what is the best tube? And there's no clear winner. I mean, you're going to have to direct the tube to the needs of the patients and what you're trying to accomplish. So the bottom line is nasogastric tubes tend to be for short term. They're very simple to place. They tend to be very easy to care. There's a range of feeding options, and they tend to be cost effective. Gastric tubes, they are usually for a longer term placement. The cost tends to be moderate. They're still very easy to maintain. They're very widely used and available. They tend to be also quite reliable, and they can function in many different ways. Jejunal tubes are for selected patients, typically to bypass the stomach because of underlying gastric condition. Usually, they are quite stable once they're placed in, and they provide decreased risk of aspiration. Now, there are certain conditions where you might need to consider doing 2 or 3 different tubes at a time, or a combination of ostomy and tubes. They tend to, sort of hover around this pseudo-obstruction picture when patients have this intermittent obstruction-like picture, and then they tend to be reliant or even TPN on different tubes for venting and feeding. Sometimes anatomy will call for that. Patients with extremely short gut syndrome can require 2 or 3 tubes. This motility and that sort of bounces between dumping and stasis, ostomy medications, and if you have allergic conditions, specifically eosinophilic esophagitis. Now, going on to formulas, we had a very excellent presentation, so I'm not going to bore you too much, but basically, I wanted to touch upon some other options. So there's liquid formulas, which typically, at least in the US, which probably is, same for the rest of the world, comes in different containers, so bag, box, and can. They usually are in a liquid or powder form, but the nice thing about this is calculated consistent nutrition. They come in a standard peptide, amino acids, and specialized formulas for metabolic, kidney, and different neurological disorders. Now, the other two groups that I wanted to touch upon is the real food formulas, which just like liquid formulas come in a can, box, and bag. They are thicker liquid, and they usually come from the inclusion of the puree fruits. The nice thing about them is also that they're calculated consistent nutrition. Now, the third group, which is sort of a new kid on the block, is homemade blended food feeds. Basically, the nutrition comes from the real foods, which we blend at home. Now, with that being said, a lot of times those home blended foods going to have also an addition or either real food formulas or formulas, because we can raise the calories and we can provide all the microelements. So if you look at the formulas and their characteristics, the standard formula is basically a formula made out of the whole intact protein chain. It is a preferred formula as a primary formula for patients who don't have any digestion, malabsorption, or allergic issues. It's not the best formula for eosinophilic esophagitis or food allergies, but it comes in different calorie concentrations within options for fiber and variety of flavors. The peptide, as we were taught, it's a shorter, partially broken down protein-based formula, much better for malabsorption and maldigestions, and especially then the normal standard formula is not tolerated well. And because we're using sometimes J-tubes, it's also a better formula because it's sort of pre-broken down for you. Once again, it is still not the best formula for EOE or multiple food allergies, but very similarly to the standard formulas, they come in different calorie concentrations, fiber options, and variety of different flavors. The amino acid clearly is, a free amino acid based formula, so that the most broken parts of the protein. It works really well for patients with GI complaints, so GI inability to absorb or maldigest, and it's also very good for the J-tube. It also is very good for patients who have eosinophilic esophagitis, short bowel syndrome, or multiple food allergies. Now, mostly it comes in a powdered form. There are some liquid forms, and they come with different flavors. But that's, the cost effectiveness is going to be a little bit higher than, well, actually quite a lot higher than the standard formula. So they're excellent formulas, but they have to be used in specific occurrences. So the real food-based formula, which is sort of this happy medium between the two, if you look and compare them to the liquid formulas as opposed to homemade blends, there are some pros and cons on both sides. So, for example, comparing to liquid formulas, they're actual foods and have phytonutrients, which basically are plant-based antioxidant ingredients. They're commonly organic, non-GMO, and plant-based. Parents are usually, very happy about this combination. They tend to anecdotally improve symptoms and may encourage oral feedings. That has not been really proven well, but accordingly to some parents, this has happened. Now, the problems with that, they still require an addition of free water. They tend to be thicker, so you are dependent on a syringe boluses feeds, and may be hard to get initial insurance coverage. Comparing to home blends, they take less time to prepare because they come in a bag. The work and preparation is slow. However, the trial and error are also going to be low. Less food safety concerns because they follow the strict, guidelines. They're very easy because they come in the pouches, so you can travel with them easy. They're school friendly, and there's more financial support. However, on the opposite side, parents will feel that they are not truly preparing the meal for the child, so there's a little bit less happiness with that, and there's less variety of those formulas available to us. So once again, what is the best formula? And, once again, it's very difficult to say which one is better. I mean, they all serve different purposes. So generally speaking, the standard formula is a formula that we use in most cases because it's cost effective, it's readily available around the world, and usually insurance covers that. peptide formulas tend to be more expensive, so you sometimes have to pay out of the pocket to gain those formulas because the insurance will not be happy to cover them. They are a little bit better or even moderately better for allergies on malabsorption syndrome, for short bowel syndrome, and for the J-tube feeds. Amino acids formula, they tend to be very expensive. Insurance frequently will refuse, so it's going to be a lot of out-of-pocket expenses. They're excellent for allergies, malabsorption, especially in the setting of eosinophilic esophagitis or eosinophilic gastroenteritis. They're very good also for short bowel syndrome and J-tube feeds. And the specialized, which we didn't touch upon a lot because this is a very specialized group for kids with metabolic, neurological, or kidney problems. So one thing I would make sure is that if you guys are working with a dietitian, they're very helpful to us. They will work with family to decide, help them transition and modified formulas, food, or combination of both. They have ability to assess the need for supplemental nutrients in those kids. They have a lot of recipes for either formulas or real food blends. They will also pick out the best consistencies. They will talk about preparation methods, forms, and longevity of those formulas or home blend foods. They have a lot of tips and tricks for best meal preparation schedule. They can educate and support families as the children transition to the adulthood. And they will allow you to help the patient transition from the outpatient to inpatient or inpatient to outpatient setting when we sometimes have to adjust the feedings regimens. So the question then becomes is what is the best outcome? I mean, so the question is what do we mean by outcome? We need to define some criteria. So is it a short-term or long-term outcome? What are the family's expectation as realistic achievements from the medical perspective? What are the measurable gains? We try to limit the adverse events. We also try to keep the costs down, both for family and for the insurances. We try to implement something that has an ease of care and use, and we definitely try to have the kids with the system support. Now, people might have different goals, but generally what I think what we're trying to do in majority of cases in approach three sort of resolutions to a problem. So one is in kids who are malnourished, you truly want to supplement them with additional nutrients and allow them to grow and develop appropriately so you can see the baby going from really this malnourished state to a baby which is a little actually on the obese side. So one is the appropriate growth and development and weight gain. Second one in children who, for whatever reason, have difficulty swallowing or at risk of aspiration or are incapable, that we allow them time to develop those oral skills so they can start to accept nutrients and normal foods readily. And clearly, starting with the tubes, but eventually you would want to have a child who's gaining weight, growing, eating, and really don't have any external devices in their abdomen. So the outcomes, I would say, the short-term goals would be allow time for the primary etiology to resolve. If it can be resolved, this is the least intrusive and the least invasive support, so that the tube choice and the nutritional choice will make a difference. We try to optimize nutrition and oral skills and allow the child to develop. In long-term settings, when a child has a condition that won't easily resolve, we look for stability and longevity of devices and the nutrition. Intrusiveness, invasiveness tends to be a little bit less important to parents. They want just optimize the best chances for the baby. Family ability to manage those tubes. Remember, this is the tube that sometimes can stay for decades to come, so family needs to be familiar and be capable of dealing with that and decrease complications along the line. So with that, I would like to wrap it out and thank, two of my families. The one on the left is my family here in States, and the one on the right is my family that, I acquired through the years being a PAAFIS member. So thank you very much, and I'll take any questions.
Thank you for your excellent presentation, Thomas. Thank you so much. I would like to check the questions.
I have a question while you're checking it. Can I ask a question?
Sure, of course, Dr. Chidam.
I want to ask about the time interval that you're changing the G-tubes, gastrostomy tubes. Is there a specific predetermined time interval that you change gastrostomy tubes, or do you use them as long as they last?
All right, so it's an excellent question. So the primary tube that gets placed in, we usually allow 2 to 3 months time before we think there's enough healing that we can safely exchange the tubes. If you have already an established tube, usually in states, you change this tube, or you should change this tube every 2 to 3 months. Now, that being said, there are, number of patients that don't follow that, and there's really not that great data because the tubes in the past used to be not as good. So the balloon breakage or buried bumper or many complications that we have seen are really not existent with the new tubes. So we had kids that really did not change the tube for 2-3 years, and those tubes are almost always still intact. So the official recommendation in state is to change every 2 to 3 months, but collectively looking at patients in the clinic, that rarely happens. It's usually closer to somewhere between 4 to 6 months.
Okay, thanks.
Okay. Thank you so much, Dr. Thomas.
Yes.
Okay,
Yes.
see. Our third guest is Dr. Mutaz Sultan. He's from Palestine. Dr. Mutaz, can you hear me? Dr. Mutaz? No? I think there's some...
Yes.
Dr. Mutaz, welcome. How are you?
I'm good. How are you? Good evening, everybody.
Yes, good evening. I'm glad to see you again.
Yep.
You
Thank
look
you all. Great to meet you.
Dr. Mutaz has COVID infections now, and we all appreciate you from Turkey. Because
Yeah, it's remote shaking, so it's a good social distancing.
Good, very good. Great. No, that's okay. Now,
Thank you. I'm feeling better. Thank you.
Yes, he would. We all appreciate you because you would rather choose to be with us instead of rest at home.
It's always good to be with you all.
Thank you. Thank you.
And please give me a chance to thank you all for arranging this great meeting. Special thanks to our great friend, Professor Soyer, and the sponsoring company. Also, big thanks to PAAFIS board for arranging this great meeting.
Okay. Thank you so much for joining us. And Dr. Mutaz Sultan is going to talk about complication of enteral feeding, how to avoid, how to manage. And yes, please welcome again, Dr. Mutaz.
Yes, I'm trying to share the screen. Do you see it?
Yes, we can.
Great. So my talk for today will be about complication of enteric feeding. Few things our colleagues already mentioned. So I go through the outline of this talk. So we'll talk about the GI complications like diarrhea, constipation, vomiting, and diarrhea, and nausea. Sorry. Metabolic complications associated with the enteral feeding, administrative complications. Then we'll go through few tube-related complications. So as our friends and colleagues mentioned, enteral feeding and enteral nutrition is important, and it is vital for our life. If we have a functioning GI tract, then this is the best option. Otherwise, we need to go for parenteral nutrition. But enteral nutrition needs a functioning GI tract. So we'll start with the first GI complication, which is diarrhea. The incidence actually is variable, and some data suggest up to 60 persons who takes tube feeding can get this complication. And as you all know, it can has a huge impact on the patients, altering fluids and electrolytes, causing malnutrition and deficiencies. And most of the time, what is blamed is the formula. Common causes of why tube-fed babies or infants or patients can get diarrhea. Infection is one of the causes. And especially in a setup of when you get C. diff infection in your institute, it can be a common cause. Formula contamination, and it's always important to ask about the hanging hours. So if it is longer than 4 hours, this might be a cause of contamination of the formula. Occasionally maldigestion and malabsorption. This we see it sometimes in malnourished patients who got secondary villus atrophy, and once you start them feeding, they have already lactose intolerance and they will start to have diarrhea. Bacterial overgrowth, in particular patients with GI surgeries and motility disorders. Don't miss overflow diarrhea. Sometimes it is not actual diarrhea, it's just overflow due to constipation. Medications can be also an important cause of diarrhea for these patients. So check the sorbitol containing medications. Sometimes antibiotics, can cause diarrhea in these patients. A lot of cases, it is not one reason causing the diarrhea; it's multifactorial. So it's always good to look to all of these factors that can affect and cause diarrhea in tube-fed infants. So what we need to do is we need to review the medication history to see if the patient's taking like prokinetics can cause diarrhea, sorbitol containing, as I mentioned, medications. Sometimes you need to check infections and send stool specimens for C. diff infections and other infections. Sometimes you need to modify the formula, and giving low-fat formulas supplemented with MCT-oil, as was mentioned earlier in the talks, it can be helpful in patients with diarrhea. And this can be helpful, especially in patients with fat malabsorption like chronic liver disease. Adding soluble fiber like pectin and other soluble fibers will, this soluble fiber will generate short-chain fatty acids, which will improve colonic water absorption and will decrease diarrhea. Look if your formula is hypertonic, high caloric formula, like the one with 1.5 cal per ml, this can cause diarrhea. So sometimes we need to change the formula to lower osmotic one, to isotonic formula. Occasionally, for a short period of time, we need to cut down the feeding rate so we can decrease the diarrhea. Then the patient will get some adaptation and he will get a better absorption. Occasionally, we use antimotility. It's not one of the first options because it carries complications. If you need to use it, be sure that your patient does not have any GI infection, in particular C. diff infection, because these medications can aggravate this infection and even can precipitate toxic megacolon. On the other hand, we can get constipation with tube-fed patients, and the causes, as our colleagues mentioned, neurological disorder is a common indication for tube feeding, and this will lead to abnormal motility of the gut, which will aggravate constipation. Patients, if they have electrolyte disturbances, they can get also more constipation. One of the common causes of constipation in these patients are inadequate liquid or fluid intake, especially the handicapped patient, and if they are giving concentrated formula, so be sure that your patient is getting adequate hydration that can improve his constipation. So how we can improve this and how we can prevent this? Be sure, as I mentioned, adequate hydration is vital in these patients. Calculate how much fluids he's taking. Review medication history. Some of these patients are on anticonvulsants, on pain medications, that can affect their motility, causing more and more constipation. So if it is possible to modify the medications, sometimes we use insoluble fibers and add it, so it can help with the constipation. Occasionally, we need to use stool softeners and even stimulants for these patients to improve constipation. And so both diarrhea and constipation are common complication of enteral feeding. One other complication is nausea and vomiting, and it has been reported up to 20% of enteral and nutrition or patients who are getting tube feeding can get these complications. And the main cause is usually delayed gastric emptying. So be careful, look to the warning signs of delayed gastric emptying, like bloating, abdominal discomfort with feeding. If you are checking the gastric residue, this is important clue that the patient is getting a delayed gastric emptying. And things to how we can improve these vomiting and nausea. So if it's possible to reduce sedation, this will help the gastric emptying. Switching to a lower fat formula will improve gastric emptying again and will improve the tolerance of the formula. Sometimes reducing the rate of delivery of the formula, and even we might use continuous instead of bolus feeds. Occasionally, we need to use prokinetic drugs like domperidone, azithro, or erythromycin. In refractory cases, we need to use transpyloric feeding also. Once all the previous measures fail, transpyloric feeding can be helpful. Patients who has persistent vomiting, it's always good to keep obstruction in mind, because this patient had surgery, they had G-tube or complication of G-tube, so consider anatomical obstruction, especially if the clinical data suggestive or the vomiting is not improving. The other group of complications we see in tube-fed infants or patients are metabolic complications, overhydration sometimes. And this scenario, we see it in hospitalized patients. Sometimes it is missed. Patient is already on IV fluid plus enteral feeding. So so it's getting more and more excessive fluids causing overhydration. Be careful with patients with heart failure. Sometimes we place gastrostomy tubes in fragile cardiac patients who are not gaining weight, and we need to boost their nutrition with the tube feeding. And be careful with these patients with heart failure and heart disease. They can get overhydration. So we monitor the intake and output. Sometimes we need to use diuretics. These patients with heart failure, they are volume sensitive. Sometimes we need to use higher caloric or high caloric formulas like the 1.5 cal formula per ml. So these fragile patients need specific considerations. Dehydration, on the other hand, also is a common complication of tube feeding, especially if we use hypertonic, high protein feeding formula. Or if your patient has stoma, ileostomy, and it's a high output stoma, and we are not paying attention to the ileostomy output. So it's always good to monitor the in and out in these patients. So careful evaluation of the intake and output, because both dehydration and overhydrations can happen in tube-fed infants. One of the interesting and metabolic complication of tube-fed infants is the refeeding syndrome. You know, this first described after the World War II. It was described in prisoners who had increasing death rate when they were started on nutritional rehabilitation. So since then, we started to describe patients with refeeding syndrome. And refeeding syndrome, it occurs in severely malnourished patients. It is characterized by intracellular shift of electrolytes. Usually, the hallmark is hypophosphatemia. So you get a switch or swift switch of phosphorus from to the intracellular part, and then you get severe hypophosphatemia. The most important part is to take risk patients at consideration and identify these risk patients, which is mainly the severely malnourished patients. Correct electrolytes before starting enteral nutrition. Be sure that the phosphorus are okay before starting enteral nutrition. Personally, I do start phosphorus supplement when I do start the enteral nutrition for these patients at risk. And you need to monitor the electrolytes, especially early in the enteral rehabilitation and nutritional rehabilitation. You should frequently monitor serum electrolytes and phosphorus. This can be a life-threatening complication, so we need to be careful of this complication. Another complication is what is an administrative aspiration. So this can be a life-threatening, unfortunately, especially pulmonary aspiration. So be careful. If your patients start to get symptoms with, tachypnea, some wheezes, fever is not mandatory because you get small amount of aspiration. Sometimes you will not get fever as a sign of chronic aspiration. So be careful to the subtle symptoms of aspiration because this can lead to chronic lung disease and more life-threatening complication. What are the risk factors for aspiration? Patients who have diminished gag reflex, especially decreased level of consciousness, patients with GERD symptoms, patients who are all the time in supine position at higher risk of aspiration. If you are using a large bore feeding tube, this can increase also aspiration. If you check the gastric residue before feeding and it's a large amount, then this also indicates that your patient has delayed gastric emptying and will get aspiration. So how we can prevent and treat this complication? Consider the risk factor, as we mentioned. It's important to periodically assess the gastric residue. Sometimes if the patient has large gastric residues, then we need to use prokinetic agents to improve gastric emptying. Anti-reflux measures like keeping the head of the bed elevated can help. Occasionally, if your patient continues with aspiration, choking during feeding, then we need to go for a transpyloric feeding. We'll go through some of the tube-related complications. Malposition of the tube also can happen, and it can be also serious. For that, tubes should be placed by trained staff with adequate post-placement monitoring and documentation. Also, the tube itself, even if it is placed in the right place, it can cause complications like necrosis in the oropharynx, sometimes infection, abscess formation. So using softer, smaller tube, especially nasogastric tube, can help with these complications. It's always recommended to confirm. If you place an NG tube, you need to confirm it either by X-ray or documenting the gastric aspirate, pH. Auscultation methods is not recommended. It's misleading, and it does not help. It's always good to monitor, document the tube marker. You know, most of the tubes, they have markers. So document it, the measures, and you can tell the family that it is marked like at 25 centimeter on the nostril. Then this can help, and you and the family know if the tube has migrated. PEG tube complications, my colleague, Dr. Cesarega, I think mentioned the major and the minor complications of the PEG tubes. So I will go through some of them, which are common complications. Tube clogging. So this is an important, and it is a common complication of tube-fed patients. Obstruction is very common. The etiology is usually two major things: inadequate flushing of the formula and use of certain medication that carries risk of clogging the tubes. The tube obstruction also, the rate is related to the diameter of the tube and how long was the tube placed. This is a list of medications that can increase tube clogging. Medications with low pH and higher osmolarity cause a higher rate of tube clogging and obstruction. So be careful when you use these medications. If you can give the medication orally, will be the best to preserve your tube. But if you cannot give the medication orally, then adequate dilution of the medication with 15 to 30 ml with each dose, and consult your pharmacist if this is feasible, it can decrease the clogging. It's always good to flush the tube before and after using the tube for both medications and feeding. Try not to mix the medication with the tube feeding. This also will help to prevent tube clogging. So, but it can happen. So if you get tube clogging, it's good to preserve your tube, open the clogging rather than replacing it. So try to flush the tube by warm water. Some use sodium bicarbonate solutions. So they clamp the tube for 5 minutes using warm water with sodium bicarbonate solution. This sometimes can help and open the tube again. Occasionally it doesn't work and you need to change your tube, unfortunately. Other tube complication is infection. Stoma wound infection. It can happen in up to 30%. Factors that can predispose to infection, it's technique related, especially if you don't give antibiotic prophylaxis. So it's recommended to give antibiotic prophylaxis prior to PEG tube placement. Patients with malnutrition or on chronic steroid use are also at risk of tube infection, and some nursing care related. This was a meta-analysis that showed that if you pre-medicate and give antibiotic prophylaxis before PEG tube placement, you will reduce the relative and absolute risk of infection. So it has been recommended as standard of care for prevention of infection before PEG tube placement. Leakage is related to infection also, and we see this complication frequently. And the risk factor for stomal leakage, as I mentioned, infection, sometimes excessive cleaning with hydrogen peroxide. So we don't recommend using it. Some of the patients, they have gastric hypersecretion. High gastric output will increase the gastric leakage. Excessive side torsion along the PEG tube. So if the PEG tube is fixed in, on-site torsion. This will increase the leakage. So we try to fix it in a way that it's perpendicular to the skin. Other factors can also affect wound healing and leakage, mainly malnutrition. So how we can improve or decrease the risk of leakage is by reduction of the risk factor I mentioned, like the malnutrition, the positioning of the tube. Sometimes we use anti-secretory therapy like PPI. You know, PPI can decrease the gastric output secretions, so it can help to decrease. Occasionally, in factor cases, we need to convert the G-tube to GJ feeding. This will decrease the leakage. Carefully, you can try this. So remove the PEG tube for a day. Then, especially if you have a large stoma, reevaluate second day and see if it decreases in size. Be careful with this and replace the tube again if the stoma size is decreasing. One wrong practice has been used to decrease the stoma size is by placing a larger tube. This will make the problem worse. So don't place the tube with a larger one because this will increase more tension, more ischemia on the orifice. So it's not recommended to do it. Colonic fistula, it's not common, but this is a serious PEG tube complication if it happens. If you have a patient, when you place the PEG tube and the colon was misplaced in front of the stomach, then this can happen. Predisposing factors, if you don't insufflate the stomach enough during PEG placement, or if your patient has laparotomy and adhesions in the past, or your translamination and fingerprinting during the PEG tube placement was not adequate, then unfortunately this can happen. How you can tell you get colonic fistula if your patient start to having water diarrhea, especially if it contains feeding, presence of stool around the PEG tube, early these patients present with peritonitis. So adequate, careful translamination is an important safety measure to prevent this complication. This is not common, but can be serious complication. It's a bad lumbar syndrome. So it is considered a long-term complication. Usually happen around 3 to 4 weeks after the PEG tube placement, and you get migration of the internal lumbar, internal disc to the gastric wall, or even the whole way out to the subcutaneous tissue. The main cause of bad lumbar is excessive traction between the internal and external lumbar. How you can tell your patient has a bad lumbar syndrome? Common symptoms: if you get difficulty in immobilizing the PEG tube, or it's not functioning, or you start to get leakage also. This is a life-threatening complication if it's not dealt in the proper time. So you need to diagnose it and take the tube as soon as possible, because it can end with necrotizing fasciitis, severe infection, and a life-threatening complication. So this is a quick case I had actually a month ago. So this is a 10-year-old who has craniotomy for brain tumor, dysphagia. I placed a big tube about a month ago. So they called me from his oncology center that his tube is not functioning, and actually, and they are starting to see induration in the skin on the tube. This is his picture. You can see how all the area is indurated. The tube was not functioning and started to leak around. So I thought, because it is the right timing of bad lumbar syndrome, so we did the CT scan, and you can see here was the mushroom. It's out, it's in the subcutaneous tissue, it's migrating So I brought the patient in, I did the endoscopy, and I could not find the mushroom inside the stomach. It's almost closed. His mushroom was very superficial and subcutaneous. So our surgeon helped me, and we removed the bumper of the tube, and the infection was treated by antibiotic with the drainage of the pus, and so we placed a temporal NG tube, and then a gastrostomy surgical was placed later. So this can be a serious complication. We need to be careful once you get dysfunction of the tube, especially weeks after PEG tube replacement. So my take-home message from the complication of enteral nutrition. Enteral nutrition is essential, major part of taking care of critically ill, chronically ill patient, but it can carry a serious complications if it is not prevented. The most important part to prevent the complication is to look for risk factor for complication. It's always a good education, good communication with the family regarding these complications in a timely manner will help to minimize these major complications. And thank you all.
Thank you so much, Dr. Mutaz, for excellent presentation. I can see one of our participants would like to ask you. Can you hear me?
Yeah, sure.
Oh, thank you. Yes, there's a question. What is the best time to check for gastric residue, and how frequent would you recommend us to do that?
So it depends on the risk factor for if patients with a risk factor for delayed gastric emptying, like bloating after feeding, neurologically handicapped patients, we recommend it once to twice daily, usually before the feed, just before the feed. So if you are giving bolus feeds, like every 4 to 6 hours, it's better to be before the feeding. So if you get more than 10% of the feeding amount, this can be significant, which can increase the risk of aspiration.
Okay, thank you. Thank you so much. So,
I have one question.
Okay, Dr. Shidam.
Dr. Sultan,
Yes.
we usually use, in cases with clogged tubes,
Yes.
we usually use commercially available sodas, especially Coca-Cola, because it works just like, a drain cleaner. Do you have any experience with that?
I know this has been used frequently. Actually, I have experience with a few patients, and it helped. Actually, the parents used it. When I looked to the literature, not much data on it. Most of the data on sodium bicarb. Which I think it can be maybe the same effect, generating some gas when you use it. So I think I agree with you. This can be a safe thing to do, and it will not harm. So it can be also used.
Okay, thank you.
So can I add something? This is Thomas Rega. So me and Mutas, when we were in fellowship in Wisconsin, we actually use Coke quite extensively, and not only for the tube cleaning, but also for some of the beezers. Believe it or not, it actually works quite well.
Yes.
Totally agree with you. Okay, thank you so much for, I would like to thank all speakers, all participants. Thank you so much for being here, be with us. And I hope all participants would have benefit for this section. And on behalf of PAAFIS, I would like to thank the Dr. Tutku and organizing committee. It's a great meeting on web, and give us a chance to a part of it. And my last words, hopefully near future is going to be okay for everyone. And till that time, please be safe and stay healthy. And Dr. Chidam or Dr. Tutku maybe might have few words for the last words, I mean, closing section.
Yeah, well, you said everything. Okay, let's see in the next session. We have to go now. We have to leave this session and we'll meet in the other session. Bye.
Hocam, diğer oturum bitti.